Naşide çok teşekkürler. Soruları Doktor Hijaz'dan sonra alacağız. Ben Doktor Adonis Hijaz hakkında biraz bilgi vermek istiyorum. Kendisi Cleveland'dan geliyor. University Hospital Cleveland Medical Center'da kadın pelvik cerrahinin direktörü, aynı bölümde başkan yardımcısı ve Case Western Reserve Üniversitesi'de tıp fakültesinde öğretim üyesi, profesör. Kendisi Beyrut Amerikan Üniversitesi'nden mezun. İhtisasını orada yapmış. Daha sonra Toronto Üniversitesi'nde ve Cleveland Clinic Foundation'da kadın pelvik tıbbı ve rekonstrüktif cerrahide eğitimini tamamladıktan sonra bu çalıştığı bölümde çalışıyor. Kendisi Kadın Ürolojisi'nin önde gelen fikir liderlerinden Amerika'da. Aynı zamanda çok iyi bir eğitimci, akademisyen, çok ciddi yayınları var. Kendisi kadın ürolojisinde kullanılan materyallerle ilgili yoğun çalışmaları var ve bununla ilgili patent çalışmaları da var. Kendisi çok uzaktan bizlerle deneyimlerini paylaşmak için geldi. Kendisine çok teşekkür ediyorum. Bir arkadaşı olarak, kardeşi olarak da tekrar hoş geldin diyorum. Ve Adonis'ten stres idrar kaçırma cerrahisinde meşlerin güncel kullanımı ve geleceği hakkında konuşmasını rica ediyorum. Please Adonis.
Good morning, everybody. Thank you, Ilker, for this kind introduction, and I would like to thank the organizing committee again for inviting me to speak here today. For those who were here yesterday, I apologize for that some of the slides are repetitive, but I think the bulk of what we're going to discuss is further dive down into what we have observed in our initial studies. So, and this follows greatly after the talk that Nashida did, which was a brilliant talk on biomaterial. So what is the purpose of the discussions today? We're going to talk about the electromechanical compaction of, or ELAC, of collagen as a biofabrication method, the treatment of stress incontinence proposed, and the regenerative macrophage therapy. So these are the three things we're going to cover today. So electrocompaction of collagen, as I told you yesterday, collagen in nature is uniformly oriented, densely packed, and failure strength approaches that of bone. However, man-made collagen is usually randomly oriented, loosely packed, and as strong as jello. So in order to use collagen as a biomaterial, you need to improve on that. We need to align better, we need to pack better, and we need to cross-link better. And that's what we were able to accomplish. Actually, all the credit for this work goes to my colleague. His name is Professor Ozan Akos at Case Western Reserve University, who's patented the technology on electrocompaction of collagen material into highly dense, pure collagen threads, as you can see here in this picture. And these threads, you can actually handle them with textile machinery. So, Colla Fabrics, with these threads, you can create anything you want. You can filament bond, you can wove, you can knit, you can do whatever you want to do to create new biomaterial. So the purpose of our work is to fabricate mechanically robust or competent collagenous tissue analogs for functional repair of connective tissue. And in stress urinary incontinence, obviously this slide is not foreign to you guys. You work with this field of urinary incontinence is leakage due to incompetence in the urethral sphincter. Sling surgery today still remains the most performed operation with over 750,000 cases done annually. So, not to belabor this, but the slings are done mostly in the retropubic approach. There are transobturator and mini slings. We'll hear about that today. So the need is to innovate in the biomaterial field because of some issues with exposure, erosion, and extrusion. So there is an unmet need in new biomaterial that we can use for slings and to extrapolate for other application in female pelvic medicine. So this slide, the next couple of slides we showed yesterday is on our initial study where we did in small animals. We took the collagen that we cross-linked with genopin, with EDC, synthetic mesh, and a biological decellularized porcine dermis called Xenomatrix. I don't know if this pointer shows. We implanted them on the dorsum of the rats, and we survived the animals for 2 weeks, 2 months, and 5 months. We harvested the tissue at these time points, and then we tested them biomechanically to see how do they fare after you remove them from the tissue. And we saw that the genapin cross-linked collagen mechanical properties converged to the native tissue mechanical properties. So this is the genapin here at 5 months. The mechanical strength converged to be equal to the vaginal tissue and the rectal tissue. On the other hand, the Xenamatrix degraded below the native tissue, and the proline mesh was still stiffer than the native tissue, and that's what we talk about when we talk about the shear stress of the difference between the native tissue and the mesh itself. So this is the early results on that we had in the small animal. We showed this promising results with increased mechanical testing functionality. When we did the histology, we see that the iliac scaffold were rapidly integrated by the host tissue, as you can see in this figure here. This is the genapin collagen mesh. This is the fibers of the collagen, and this is the new collagen deposition in between the interstices of the collagen. Xenamatrix, however, there was no infiltration whatsoever. This is the proline mesh like we have demonstrated there is collagen deposition between the fibers of the polyproline. EDC was less of a robust response there. So, and this slide we showed yesterday showing that there is as early as 2 weeks new collagen deposition within the interstices of the mesh. So, we believe that because of the cross-linking, this is the advantage. And genapin scaffold held up strength in long term, whereas EDC fall apart. Genapin cross-linked scaffold had greater pro-regenerative macrophages in their milieu, and the pro-regenerative M2 macrophage markers, CD206 and 163 positive cells, were greater in the genapin group. So the hypothesis that we derive from this work is that genapin induces a pro-regenerative polarization of the macrophages. And this led us to submit a grant to investigate that, and the next few slides you will see the results of the pro-regenerative macrophage therapy. So, immunoregenerative use of macrophages. Macrophages are central to wound healing and regeneration. There are circulating monocytes. They are M0 non-activated in the form, in the blood. And when they are activated, they can go either into M1 phenotype or M2 phenotype. And M2 phenotype is the phenotype that's anti-inflammatory. So the M2 macrophages, they express trophic factors, VEGF, HMGP1, PDGF, FGF, IGF, and these have role in vascularization, in chemotaxis, and in matrix formation. And the use of the M0 for regeneration has been done in other systems. So the attempt that we want to do is to realize the M2 driven immunoregeneration in combination with biomaterial as highly limited in the literature. So we wanted to do that testing here. So the macrophages can be easily derived from the blood. They're accessible. And then we can take them, isolate them, and try to use them in a minimally invasive approach. So the research question here in the next few slides is is genapin responsible for the polarization of the macrophages? Because that's the hypothesis we had. The second research question is, does direct delivery of M1 versus M2 on the iliac scaffold differ in the terms of regenerative potential? So Ilaha Isali is our postdoc who worked with us on this project. We published our first paper on the in vitro studies. It's a busy slide, but essentially what we did, we took the monocytes from the rats, we isolated them, and then we polarized them. We had the M0, the M1, and the M2. We polarized them through a special exposure to chemokines. And then we loaded the M0 on the genapin cross-link mesh, the M1 on the genapin cross-link mesh. We loaded M2 on the mesh, and then we put M0 in the uncross-linked mesh. We want to make sure, is the mesh itself that's causing the M0 to differentiate? And then we put M0 with genapin in solution to see if M0 is genapin the cause of the polarization. And then we tested for these cells differentiation, and we found out when you put the M0 in the presence of genapin in cellular-based solution, it becomes M2. And when you put M0 in the cross-linked collagen, we have M2. And when we put M1 with the genapin cross-link, it becomes, the number of M1 decreases. So these studies showed us with a high suggestion that the genapin is the reason why the M0 is, where we have a higher M2 in the tissues. So genapin is the main driver for the pro-regenerative M2 polarization of the macrophages. Then we wanted to do this test in vivo. So we took, again, the genapin cross-linked scaffolds here, and we had an empty scaffold that we implanted. We had an M0 loaded scaffold, M1 loaded scaffold, and M2 loaded scaffold, and we implanted them, and we harvested the tissue, and we looked for mechanical properties again. We looked for histology, immunohistology, and implant remodeling. So this is the mechanical testing of the tissue when we harvested. The M2 seeded scaffold had a greater modulus at 9 months. You could see that here. So at 9 months, the M2 scaffold had the greater modulus, which is a good mechanical property. And when you look at the histology, the M2 seeded scaffold had the greater cellularity and more proliferation and or chemotaction of the host cell. So you can see in the M2 scaffold here, more cells, and there is more proliferation. When you look at the histology, and the first graph here shows the percentage of total area of collagen thread. So this is the actual collagen thread in the dark blue. In the M2 loaded scaffold, there was less of the collagen threads. You could see that significantly going down. And the percent of new collagen increases in this area. And the thickness of the fibrous encapsulation, as I talked about yesterday, is minimal when you load the scaffold with M2. So the fibrous encapsulation to start with, as I'll show you later on, is very, very little. But when you load this scaffold with M2 macrophages, it becomes minimal. So M2 delivery resulted in superior regeneration, better mechanics, better remodeling, and diminished fibrous encapsulation. Now, to further look into this, there are 4 types of M2 macrophages. There is M2A, M2B, M2C, and M2D. Which one of these M2 macrophages or subtypes is responsible for the effect that we see? So this is a work that we started doing. We have a grant under resubmission to essentially isolate the different potent M2 subtypes and load them on the scaffold and study their effect. But essentially, we were able, with the work that Ilaha did and Ozan, to take these macrophages, polarize them into these different subtypes, and then we studied what are these macrophages secreting. So we did the chemokine evaluation of these macrophages, and you can see here, for example, in this slide, that the M2C has a high secretion of interleukin-10 and TGF-beta, and M2A has a very high secretion of TIMP1, which is an inhibitor of the MMP. So to further study the effect of these macrophages, we picked the M2A, M2D, and the M2C phenotypes, and we did what we call co-culturing. So you can see on this slide, we put here the M2D cells, and in the bottom, we put the HOVAC cells, and we studied on the time point at 3 and 7 and 14 days if there is a new vessel formation. Also here, we did the M2C, and we put L2 929, which is a fibroblast, to study collagen production. And you see that the M2C induced increased collagen production, and with the M2D, we have increased neovascularization. So our further work is to try to refine which type of the M2 macrophages is responsible for the favorable outcome. This is the slide that I showed you yesterday. This is the work that was published by Dr. Khalifa, who was one of our postdocs. This is where we took a hybrid type of collagen mesh. This is a mesh that we created with collagen in the middle, and the arms were more made of proline. We implanted them in sheep, and we harvested sheep at 6 months and 12 months. We did a comparison with the Link sling, which is a Boston Scientific sling, and we did the mechanical testing that shows equivalent mechanical properties at 6 months, and that mechanical properties were still persistently good at 12 months and comparable to native tissue. This is another study where we took the what we call the design freeze of the biomaterial in the way we expect to be done in human trials. So this is the results of the pivotal study in sheep, where we put the slings in at a total of 10 sheep, and we've survived them for a total of 9 months, 3 and 6 and 9 months. And when we harvested the tissue, you can see that there is still sling material at 9 months here in the retropubic space. And this is the mesh underneath the urethra, and this is the mesh in the muscle of the rectus muscle. And you can see the new collagen formation, low level of infiltration, of inflammatory response, and a good integration with the tissues around them. So this is an abstract we submitted recently to SUFU, essentially looking at the results from this pivotal trial. You can see on the mechanical properties level, explant were significantly stronger at all time points compared to hydrated, naive colosling due to tissue ingrowth and de novo collagen deposition. Strain and modulus testing were consistent over time with values similar to that of native tissue. So I would like to thank you for your time. I would like to thank our funding agencies that has funded this work so far. This is still work in progress. We have a grant application to do a pilot clinical trial in human. We have done a lot of biocompatibility, toxicology studies through third party, and the results are looking very promising. So we are hopefully once we get the funding, we'll be on the verge of doing the first in-human clinical trials with this biomaterial. Thank you for your time.